Thank you. It's nice to be here. I just want to say right away that I want to honor the fact that there's a lot of wisdom and experience in the room. And if we had more time, I wish this could be more of a conversation. So if we can do that at the end, let's shoot for it. So if things I'm saying up here today are not necessarily brand new information to you, which they probably aren't, hopefully the way I'm talking about them or the words that are used, are for you to take back and use them in whatever way might be useful for you going forward. So here is our plan for the day. Talk about some underlying assumptions. Let's talk about what we mean by trauma, what does it look like, and then briefly touch on some of the strategies or considerations that we think about when we're working with young children. Sound okay? All right. So reviewing three kind of areas. One is that when we're talking about children with trauma, we want to always have a developmental lens in mind. And that's because whether we're talking about the parents or the children, we want to have a developmental lens in mind. So we're assuming we know that development is cumulative, and we also understand that development is transactional. So when we talk about transaction, we're talking about understanding in the last 20 to 30 years how much more of an active participant an infant is from the beginning in terms of being an engaged partner with their caregivers in terms of eliciting certain kinds of interaction. So for example, if we have an infant of a depressed parent and the infant learns that they have to hit a pretty high threshold of noise or whatever to get their needs met, that's the way they learn to understand the way the world works. And it may be very adaptive for them in that setting where their primary parent or caregiver is not as reactive as she might otherwise be. But you translate that into an early care and education setting, an infant who's learned to be irritable, ornery, and hit a pretty high threshold is going to not elicit the best from other caregivers. But so that's how we understand that and when you think about that in the context of early experience, you realize how critical it is. We also know that development unfolds within relationships. I think we had sort of a glaring example of that in the 90s when with the Romanian orphanages, where we saw children whose physical needs were met, they were fed, they were clean, and many of them died, and many of them were profoundly impaired because they did not have primary relationships. So as a species, we're biologically wired that way. Our survival literally depends on our ability to maintain close physical proximity to a caregiver, or we die. So then as caregivers, we're biologically wired to be aroused in the presence of infants and young children. And we'll come back to that later in the context of those of us who work in the context of trauma. We are biologically wired to be aroused, and that has implications for how we respond and work in those situations as well. And then that research tells us it's the quality of the relationship between the child and the parent or the primary caregivers that is the most important predictor of a child's developmental outcome. Now, that does not mean that the parent is the only significant influence, and I think we know that, or we wouldn't be here at a children's mental health conference. And then that brain development is experience dependent. So the brain develops from the bottom up. So the part of the brain that is most developed at birth is what keeps us alive, our heart rate, our breathing, our respiration, all that stuff. And then based on our experience, the synapses are forming at a rate of what we understand now is 700 synapses per second in the first year of life. Isn't that amazing? And that's all happening based on experience so that our brains can be as efficient as possible depending on what are the survival needs in the particular environment into which we're born. And the more an experience is repeated, the stronger the connections become. You know that. So when we're talking about when we're talking about in the context of trauma, I'm going to be mentioning regulation a lot, arousal and regulation. That is absolutely one of the primary functions that we as caregivers serve, because the infant is not born with the capacity for self-regulation. So that, I wake up, I'm hungry, I'm wet, I'm alone, and it is literally a physiological state of arousal 911. And so if the caregiver comes in, picks up the baby and goes through the checklist, are you tired, are you hungry, the brain's wiring at 700 synapses per second, and it wires in response to arousal, soothe, arousal, soothe. So eventually, in a matter of a very few months, an infant simply hears the voice of the caregiver and is able to calm momentarily, because their experience is, my needs will be met. This is not a 911. But what happens when that is not the child's primary experience, we I think have these lovely studies that Megan Gunner and others have done with cortisol, which is one of the stress hormones that is produced in response to stress. We have cortisol in our system all the time. It's higher in the morning, it gets lower in the afternoon, probably from the stress of getting out of bed, I don't know. But she did this lovely study in the 90s where they assessed using the strange situation paradigm in the lab, where they have the mother and the child in the room together, and the stranger comes in and the mother leaves, and it's a research paradigm. It's not a diagnostic procedure, but based on the infant's response, or the toddler's response rather, to how they respond to the parent when the parent returns, they categorize the child as securely attached or insecurely attached. And there's several categories of insecurely attached. But for our purposes, they then followed these parents and children to the doctor's office and for well child check at about 18 months of age, when children get shots. So I've got the securely attached child, the insecurely attached child, and they've just gotten a shot, and those children may look the same. They're both crying. Shots hurt. But if we assess their cortisol level, in other words, the brain's response to this stress, and it's easy to do in children because it's excreted in the saliva, so you suck on a cotton ball, the child who's insecurely attached has a much lower level of cortisol than the insecurely attached, whose physiological response to this stressful situation of having shots is much higher. So what that tells us is that the relationship is actually providing a buffer, a physiological buffer, as well as a psychological buffer to the child's response to a stressor. So when we think resiliency, when we talk about how is it that some children, and it's I'm oversimplifying, but these are the things that contribute to when bad things happen. Why does one child have a catastrophic response and one child seems to sail through it? This is a piece of it in terms of how we've built resiliency. This also makes the case for when we're talking about trauma, why we need to think about it from an individual perspective, why two different children may have very different responses to the same trauma. Because we've also got temperament in the mix, the child who's just temperamentally more reactive versus the child who's temperamentally more easygoing. And what is the child's stage of development? So just intuitively, if you think about it, for those of you who are parents, let's say you've got a 3-month-old baby, you might, are you going to be taking them to the state fair and into the fun house? Probably not. But if that child were, depending on the temperament, but if you took a child into the fun house at an older age, their experience and their developmental stage, their cognitive ability to process what's going on allows them to tolerate the same experience. But we have to measure that, and we do so hopefully intuitively based on what we know about this child's temperament and this child's developmental stage and how much of that they can tolerate. So, ta-da! Those are our basic assumptions today. One of the things that we know very clearly is that trauma impacts the child's developmental trajectory. And this is true whether we're talking about, and again, if you go back to the development is transactional, then something that happens to a child We're hoping a child is developing along a healthy trajectory, but let's say something happens and with the parent-child relationship, or perhaps the child experiences an acute trauma, let's say an invasive medical procedure. Depending on circumstances, that may set up a different set of expectations the child has for how the world works, what kinds of interactions that child then elicits from others. When we hope, what we want to do when we think about intervention is we're trying to keep that developmental trajectory on track. So a child, again, may have an experience, let's say a medical trauma, but if that child is surrounded by social support and there is more of an innate resiliency, that developmental trajectory does not have to go off track. The other critical thing is that trauma anywhere in this system, this relationship, this parent-child primary caregiver system, it impacts the whole system. So let's say, for example, for those of you who might be doing home visiting, let's say you have a home visiting case where you have a mother and a child, and this is a mother who experienced her own complicated early trauma history. She may have experienced abandonment in her childhood in terms of feeling like her needs were never met, and she has this baby and things are going great until that baby starts to walk. That baby becomes mobile and literally starts to walk away from her, or starts to say, no, my way. Based on that mother's earlier trauma experience, she may re-experience that and attribute that to the baby. You're just one more person who's leaving me. You're one more person in my life who doesn't respect me. So that's where if we put on that trauma lens, sometimes it can be useful to understand, or at least have different kinds of hunches about what we're seeing in terms of parent-child interaction. Does that make sense? So when we think about what do we mean by trauma, the key word in this first bullet point is perceived. So events that are perceived as threatening the life or physical integrity of a child or someone important to a child. That's where we worry so much about the impact of domestic violence on young children, that a young child witnessing domestic violence threatens their physical integrity when they're seeing their primary caregiver attacked, as it would be if they were the ones directly experiencing the violence. And it's this sense of helplessness that I have no control over what's going to happen to me in this situation. And you get the physical effects of that trauma, and that it completely overwhelms the child's coping strategies. So again, you see how it is experienced individually. This child may have more robust kinds of coping strategies for a variety of reasons. This child may have many fewer coping strategies, and their experience of the same traumatic event or series of events may be very different. So trauma can be experienced acutely. Things like a car accident, a dog bite, medical procedures. And I'm going to be talking less about that today and more about the trauma that we see in parent-child relationships. It can be direct abuse or neglect. These are sort of obvious. I think the thing to point out is oftentimes we say, well, it was just neglect. For a very young child, neglect is experienced as a very profound trauma, as much as physical abuse. Because, again, if we go back to this definition, it's that sense of helplessness, of overwhelming terror and horror, and overwhelming the coping strategies, neglect of having basic physical needs met for a very young child is experienced in just that way. Witnessing violence, we talked about that. Separation from important people. Now, again, keeping in mind that, for those of us who are parents and all of us who care about young children, that's why the title of this is Trauma Happens. Trauma happens, whether our intentions are the best, but it's how we help a child cope with it. So separation happens. And historical trauma that Evie's going to be talking about more. we can't underestimate, and that's where we have to think about. I'm not going into it. Evie is, but culture surrounds all of this. So, for example, I once heard this just breathtaking testimony by a Native American woman who was at a conference in North Dakota, and she talked about her. She was a middle-aged woman who had come to learn more about the influence of her people's historical trauma. In that, she said, "I never showed much of physical affection to my children, and my own mother never showed much physical affection to me." And as an adult, she had a conversation with her grandmother that helped link it together, which had to do with the history of Native children being sent to the boarding schools. And so to show a child the kind of affection you might want to do naturally was considered to be a disservice to that child who was going to be taken from you at a young age and sent to a school, and was a defense mechanism for the parent who was anticipating this. So generationally, she was able to go, she said she had this amazing conversation with her now adult children to say, the way I did it wasn't the way I hope you do it with your children. And the reason I understand that I did it is that we can make a decision to do it differently, but without thinking about it. That's how some of these intergenerational kinds of things go on, how we see historical trauma. The trauma that when I prepared this, that I'm thinking most about is what we call complex trauma. And this is the trauma that's caused by the very adults who should have been protecting and caring for a child. We worry about this very much because it's the kind of trauma that's associated most with disorganized attachment, which we know is most likely to be associated with persistent mental illness as an adult. And so what we're talking about is the young child for whom the caregiver is both the person I need to turn to for care, but this person also frightens me. So it becomes literally an impossible dilemma for the child. What's important to note here is that it doesn't just happen when the caregiver, the primary caregiver, usually the parent, is themselves an abuser. It's part of the dynamic that gets set up in domestic violence situations or families who are living in wartime situations or in very dangerous neighborhoods. If the way I learn emotions and regulation is that I need this regulating partner of my parent, and when I turn to that parent for comfort and I see the parent is frightened, how can I be regulated by a caregiver who is herself so dysregulated and so frightened? So the fact that she's frightened and that dysregulated terrifies me as well. So she may be a very loving parent, but if those are her living circumstances, then I experience her as frightening as well as nurturing. And usually when we talk about complex trauma, we're talking about trauma that goes on for a long time. So the kind of living environmental situations where the trauma becomes quite chronic. So if we think about this in terms of, on one of your handouts, there's a bibliography that has these websites. But talking about the stress continuum comes from the Center for the Developing Child. Fabulous website. And so it's another kind of set of language to talk about the trauma experience. So if we think about the trauma-stress continuum, stress is not all bad. There is positive stress that occurs. Let's think about a 6-month-old baby who's sitting on the floor and they are getting ready to crawl. And they can see that toy and they can't get to it and they're getting frustrated. That's positive stress. That's the stress that is motivating that baby to leap to the next step. I think as adults that happens all the time. Sometimes we got to get a little bit uncomfortable before we're going to make that personal change that we know we need to make. That's positive stress. And it's what happens when, God forbid, you give birth to a second child and your beloved first child has to cope with a sibling. That's a positive stress. And the kind of support that first child experiences around that is going to contribute to how well they ride that out. But with adult support, those positive stress experiences, and again, so defining it as positive stress has to do with how much support the child has to go through it. But the child actually gets that sense of mastery. For example, it's why we want children, that book by Dave Walsh, know why children need to hear it and how parents can say it. Because if children never have that experience of being frustrated, I can't have everything I want exactly when I want it, then I'm never going to learn to manage those feelings. I'm not going to learn to regulate myself. So again, that's the kind of stress that as caregivers, we can manage to a child's, that contributes vastly to a child's resiliency. If I can learn to manage this stress in an age-appropriate way, how much more resilient I am for the stresses that are inevitable in life. Tolerable stress is the stuff that happens that may not be optimal. Tolerable stress may have the potential to derail development. It might be, as a parent, maybe my elderly parent is very ill and I have to leave home for a period of time, or I'm highly stressed for a number of reasons. And so my child experiences that stress. But how we come out of that in the end, how well that's acknowledged and supported and worked through, can again provide the buffer from that derailing development. So tolerable stress happens. It's the toxic stress that we worry about. The toxic stress is the complex trauma. It's the persistent kinds of traumatic experiences that children and families have to deal with. And again, if we think back to the cortisol, we're talking about the stress going up, the cortisol raging, and it stays there because the stress never really goes away, or the perception of stress never really goes away. It's too much stress over too much time with too little adult support. Because when you think about it, if we go back to the brain development stuff, what happens, stress, again, this is a basic biology. It has a survival instinct, right? I'm walking down the street. There's a tiger running, escaped tiger coming from the zoo. Now, if I stop and say, there's a tiger coming down the street. I wonder what I should do next. Too late. As opposed to, when I see that tiger running towards me, I literally disconnect from the thinking part of my brain and I move, right? My personal example is the time I was driving to the car wash with my toddler child in the back seat, and somebody cut me off, and I'm very close to having an accident, and I let fly a word that if my frontal lobes had been connected to the regulatory part of my brain, I would not have said that word in front of the child, who proceeded to repeat it perfectly in front of his grandmother and father for the next week. But that happens to us all the time, right? That's a survival function. And so when we respond, these are some of the kinds of responses that we get. We can get flight. We know that, fight or flight. And that's the very dysregulated, aggressive attempts to manage, or just that, no, you don't. It's an adaptive way for a child might be the kid who has to say no before that they can say yes. No. Oh, that's what you want me to do? Oh, okay, I can do that. It has there's an adaptive piece to that. My personal example would be Anthony. I spent 5 years as a therapist in a preschool day treatment program, so I was with children for 5 half days a week. And often the kids were in the program for a year, sometimes longer. And Anthony was one of those kids that his immediate reaction to things, if we told him no, he went on the offensive. And this was a child with a very significant trauma history. Now, when you think about it, Anthony being told no was a trauma trigger for every disappointment, every denial of basic care that he'd had. Just hearing no would set him off into these prolonged sort of dissociative, rageful tantrums. And that was both an example of fight and freeze, I guess, in a sense, because he would become dissociative. But it's the kids who have the defensive response to everything. Then there's the children who tend to flee. Those are the kids who shut down. The child we worked with was a 2-year-old named Troy who came into the program and was in foster care with his 2 brothers and had been removed for neglect. And this was a kid who really deeply, deeply was pining for his mother. And he didn't play, he didn't interact, and over time this changed, but he would be an example of a child who is completely withdrawn. Children, the younger they are, the more susceptible they might be to this kind of coping response to trauma. Freeze would be, we would think about more the dissociative response to trauma. Allison, who was 4, was in our program with her 3-year-old brother, and their biological mother had one of her supervised visitations was in our classroom on a weekly basis. And when the mom got ready to leave, the 3-year-old would have a complete meltdown, just crying and sobbing. And Allison would just walk away. She would go start playing with toys. Other children in the room would become more upset about the fact that Allison's mother was leaving than Allison was. However, 20 minutes later, after Mom had gone and we're sitting at the snack table and her cracker dropped on the floor and broke, the tantrum that ensued lasted 30 minutes. Not about the cracker. But it was so painful to say goodbye to her mother that she would literally dissociate, which of course you can imagine from her mother's perspective meant that she didn't care and she didn't love her and so on and so forth. But the other one is tend or befriend, which is kind of related to some of the others. These are the kids that get really clingy, and that would be, you would expect to see that again, more often perhaps with younger children. But Troy's older brother, Tommy, had this strategy. He was a 5-year-old whose response to his experience was to be the caretaker. He was in charge. He wanted to take care of his little brothers. He wanted to take care of the adults in the room because that's the way he had learned to adapt to the chaotic circumstances of his life. And he was very resistant to our attempts to remind him that this is a place where kids get to play and grown-ups will take care of kids. It was very difficult for him to let go of that caregiving role because that was the way he stayed in control of this really unpredictable world. Any questions about this? Yeah.
Did you often see a mix-up, a mashup of a befriender and a fighter?
Absolutely. The question is, did we often see a combination of these? And absolutely we did. Yes. It's not a simple categorical. Yeah. Anything else? The other thing we get are these perceptual distortions. Mary Dozier is at the University of Delaware has developed a curriculum for foster parents of very young children called Attachment and Biobehavioral Catch-Up, if any of you are familiar with that. She uses this shark music from Jaws. Da, 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 da. So she has this slide where she shows a scene of like a beautiful beach scene and playing to Paco Bell's Canon. And then she has the exact same scene with dun, 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 dun. And it's a really powerful tool because you can literally feel a physiological response. There's nothing different about the scene you're looking at, but that's an example of perceptual distortions. I see danger where you don't see danger based on my previous experiences. So it's the kid who's standing at his locker in junior high and the kid behind him trips, knocks into him. Now, if my experience is that people are out to get me, I can't trust anybody, I'm on my own, my response to somebody actually bumping into me is probably going to be one of those aggressive responses, because I know you're out to hurt me. That's the way the world works, as opposed to a kid who's had pretty benign or supportive life experiences, and they're like startled, but turn around and say, geez, what happened? So when something is ambiguous, I don't know how to interpret this, I'm going to interpret it based on my life experience, my deeply embedded understanding of the way the world works. And if it's been that people are out to get me, adults don't take care of kids, if I don't do it, no one will, then I'm going to have those negative interpretations of things that may be very far from negative. And then these desperate solutions. This is the kid, you think about children who've been physically abused, for example, often tend to become pretty high risk for being re-abused. Because you set up a dynamic where I've learned that the way the world works is something happens and I get hurt, and I need somebody and I get hurt. And if that's negative attention is better than no attention at all. And so I need to test the anxiety that's created by now I'm in a foster home or now I'm in a school setting, and that's not the way the world works here. I have no reason to believe that. So I'm going to test it and test it and test it to make sure that my understanding of the way the world works is true. And so I'm going to push you and push you and push you, because the anxiety waiting for it to happen is worse than having it happen and getting it over with. Does that make sense? So it's that, and that's what we see often with kids who've tested. It's like, what's in this for you? Why this compulsively negative attention? He's just looking for attention. And let's think about what's that about? So it literally affects the way the brain develops, because the body stays activated looking for danger. So my teacher in that was Michael, same classroom, 3-year-old, again, similar kind of trauma history as many of the children in the room. And we're in the gym, which is about half the size of this, bikes, balls, and everything. I'm as far across the room from Michael as I can be when I rubbed my eyes. And he screamed from across the room, "Michelle, why are you crying?" Now, I guarantee you, the least interesting thing in this room. Why is he even paying any attention to me? And why would he assume that I was crying because my eyes itched? Well, because Michael's life experience was that his survival depended on knowing where the adult in charge was and what kind of a mood she was in. So that's an example of how he was at that hyper-aroused state all of the time. He was always on alert. The other thing that is really important in this is when we think about trauma memories, and Katie's going to be getting more into this, but trauma memories, memory gets encoded differently during traumatic events than it does from regular events. It happens in bits and pieces, and it's the part that gets really encoded, embedded more deeply, has to do with our emotional state at the time and the sensory information that is around us at the time. And so one of the things we say is, well, until not that long ago, we believed that if trauma happened to babies, well, they didn't remember it. They remember it in a way that makes it almost harder to access in terms of our interventions, because they don't have a verbal frame for what happened. It's almost like the memory is in the body, and that's where you get those trauma triggers. I mean, we all have that experience of that, you smell something and it just like zaps you back in time to a particular memory. One of my favorite smells happens to be the smell of sun-dried horse manure. Okay? When I was a teenager, I had a horse in my backyard, and I loved that horse. So, but I can just get this vivid experience. And I think, with bread baking or whatever it is. But that's some of that kind of, but imagine that being associated with a very negative or traumatic experience. I may not even have a visual picture, a frame for what that experience was, but I have the reaction. Okay, and that it's that physiological heart beating, palm sweating, it's that autonomic response to a particular thing. I don't know where it came from, but I know how it feels. So that very young babies remember. And that's something we haven't always understood. So when you think about it in terms of this alarm system, and again, that we need this alarm system. It's about survival. So something happens, like the car pulling in front of me, and those adrenaline, cortisol, those stress hormones get released, and I have an appropriate response that keeps me alive or whatever, and then the threat's removed and everything returns to normal. That's the way we hope it works, right? But if we're talking about chronic stress or that kind of complex trauma, the brain releases those hormones that helps the body respond, but the threat continues or is repeated often enough that the child, like Michael, literally stays at this high level of arousal. Now let's take this kid to first grade, and we'll put him in a desk, and let's ask him to do worksheets. How's that going to go? It's not going to go very well, because his energy is expended on staying alert to what's happening in his environment. So when you think about it, and let's take it from an adult's perspective. Hi, I'm your new home visitor. And I'm a mother, let's say I'm an 18-year-old mother I'm a single parent, baby daddy left, and I have this new baby. And not only that, but I am culturally or racially different from you, and my experience with white people hasn't been so good, or my experience with systems, and I'm sorry, but we all represent a system, and I've had only negative, school sucked, whatever it is. I mean, and it's often intergenerational. If we're talking about poverty here, then we're pretty much, if it's intergenerational poverty, we're often looking at multiple factors that have contributed to those negative experiences with systems. So I'm going to have, again, that distorted perception. But it's based on my life. I'm going to experience you and your attempts to help me very differently than you intend them. So those are the kinds of things that I see danger everywhere. I have no one to count on but myself. So another way to think about this is with the ACEs studies. Have many of you familiar? Glennis Edwall did a presentation yesterday. Actually, this is coming to Minnesota, where they're collecting a lot of this data. The ACEs stands for Adverse Childhood Experiences. And a couple of decades ago in Southern California, there's a huge HMO called Kaiser Permanente. And they were looking for some of the underlying causes that predicted some of the very expensive adult chronic diseases, like heart disease, obesity, diabetes, depression, I can't remember what else, but they sent out these very, very lengthy questionnaires to thousands and thousands of members of the HMO. So these are people who were insured. So these are people who, by and large, are employed, and so on and so forth. And much to their surprise at the time, what came back to them was the most reliable predictor of these adult chronic diseases and early death had to do with the early experiences that these adults had had. And the more of these negative or adverse experiences they'd had, the more likely it was that they would have some of these chronic health conditions. And they defined adverse, on the left is how they defined the adverse childhood experiences. So emotional, physical abuse and neglect, many of the things that you would think of. And since then, they've done looking at numbers of factors that these are associated with. And this is not by any means an all-inclusive list, but much higher incidence of alcohol and drug abuse, domestic violence, all the things you see here. And then think about the the next set of risk factors and the implications of this for my ability to parent and to parent a child in as healthy a way as possible. And Robert Anda, who's one of the authors of this study, has been to Minnesota a number of times. And I was at a talk that he gave, and he said what they're finding with this information, by the way, all of these papers are available at the Center for Disease Control, the CDC. If you just put in your search engine, adverse childhood experiences, you can pull up papers that are specific to adolescent pregnancy, to alcohol and drug abuse. So there's just a rich literature around this. But Robert Anda said, interestingly, from a public policy perspective, they're finding that if you want to talk about child abuse to legislators or policymakers, it's kind of like, yeah, whatever, how long have we been talking about child abuse? Talk to them about adverse childhood experiences and the medical costs that are incurred with chronic disease in adulthood, and suddenly there's a lot more interest. Now, we have a bias that makes, at least I have a bias that makes me go, what? But whatever works, right? So one of their findings is that, and again, so along the horizontal, you have how many adverse childhood experiences, 1 to 2, up to 7, and how many children are documented as having developmental delays. And you can see that it's almost 100% of children who have had the 6 or 7 of these adverse childhood experiences show significant developmental delays. Pretty profound. The other thing is that very young children can have post-traumatic stress disorder. We think of that typically in terms of veterans of war, but for those of you who've had the DC 0 to 3 training, post-traumatic stress disorder in young children is one of the diagnoses, and many of the symptoms are very, very similar. In terms of the trauma triggers and the arousal, very young children tend to respond with by being physiologically disorganized. They have trouble sleeping, they have trouble eating, they're irritable, they're fussy, they're difficult to soothe. And ironically, again, what happens to kids with trauma, young children, is their perception of danger. Again, children learn what's dangerous from their caregivers, right? So you have the 7-month-old, and somebody walks in, and the baby's in my arms, and baby sees the stranger approach, and the first thing they do is look to the parent to say, "What do you think? Is this guy okay?" And so if they haven't had that reliable gauge, that emotional reference for what's dangerous, what's not, a lot of times these kids look pretty reckless. They look pretty accident-prone. They have little ability to focus. Or you may have kids that seem grown. They're very independent. Precocious independence in a young kid is not good news, depending on the circumstances. So, for example, in preschool day treatment, where you would typically, with preschoolers, you would be teaching them to pour their own juice and, a lot of self-help skills, we actually did the opposite. We would have the adult, as the therapist in the room, I would pour the juice, and the children, so that what we were doing was filling in gaps. Adults help kids here. Adults here will give you as much as you want. We will take care of you. The other interesting thing, when you think about transactional nature of development, is that Pollack has done some very interesting studies showing abused and neglected children, and then a control group, faces with different emotions. And what he found was that neglected children, so children who had not necessarily experienced physical abuse, but who had experienced neglected, had difficulty discriminating between emotional states and would more often err on the side of sad. Children who had been physically abused often interpreted emotional expressions as angry. So if I have a neutral face, remember that if it's an ambiguous situation, I'm going to interpret it based on my life experience. So if I simply turn and look at you, and your experience is that adults are scary, adults hurt kids, I'm going to see MAD where MAD doesn't exist. And so then again, when you think about the transactional piece of this, this means this is sort of a piece of why children who have these traumatic early experiences often continue to have such difficulty with social problem solving, social skills. They literally have difficulty interpreting social cues and responding appropriately. So I'm not going to go through these because you have this in your handout, but just how the key developmental tasks are affected by the impact of trauma. So birth to 5, and again, these are from the National Child Traumatic Stress Network that Carrie mentioned is a fabulous website. So I really encourage you to go on that. So again, this is where Katie's really going to talk much more about this, but when you think, there are some very interesting animal studies that give us insights into this impact of trauma on parenting. And one of them is what happens when there's poverty, a lack of basic needs. That one of the things they find is that it creates stress in the parent, the caregiver, when basic needs are not assured, when you think about homelessness and poverty. And so in rats, they took away the nesting materials, or some of the nesting materials, and what they got were abnormal mothering behaviors. So the mother wasn't perhaps licking the pups, which is the way other rats regulate their baby rats. So there was diminished licking behavior, for example. And so what that did was create a higher level of arousal chronically in those rat pups who were not experiencing the optimal regulation that they needed to develop optimally. And so those rat pups grow up not knowing or not transmitting those optimal parenting behaviors to their own next generation of rat pups. And so it goes in terms of this intergenerational thing. So again, when you think about the pervasiveness of intergenerational poverty in our country and how that can affect literally at the neurobiological level how we parent and are parented. Because a history of trauma for a parent makes it difficult for them to recognize what is safety. If I grew up not knowing what's safe and what's dangerous, and it seems contradictory, but one of the reactions is I'm going to have trouble keep protecting my child because I never have the experience of being protected. I literally can't see danger sometimes when it's in front of me, or I see danger everywhere, and I may deny my child some of the development enhancing experiences that you would hope for. And also, again, when we're talking about the kids and the kids having trouble staying regulated because they're wired to be much more reactive, the same is true of the parents. So if a child learns to regulate by being regulated from the regulatory partner, and my regulatory partner can't regulate, so it goes. Which is, for any of you who work with adolescent parents, that's one of the, with that, we worry about adolescent parents because adolescents are not exactly well known for their ability to be regulated. And now we're giving them a baby and asking them to teach that baby to be the regulating partner for that baby. So the same is true in trauma. I don't have a repertoire of how you deal with stress in a healthy way, if that's been my experience. And I certainly don't trust other people. And again, think about our dynamic in working with people who've had these experiences. And in fact, my own child may become a trigger for my own trauma. An experience I had was I'd done some mental health consultation in child care, and one of the centers where I worked was a wonderful child care center. And there was an infant teacher who was a young woman who was very committed to being the best infant teacher she could be. I really knew this about her. And one day I walked in the classroom, and there was a 10-month-old baby strapped in a high chair, screaming, seriously distressed. And the teacher was standing with the high chair tray, wiping the high chair tray, staring out the window. And I said, good morning. Would it be okay if I pick the baby up? And she kind of went, oh, yeah, sure. And seemed very surprised. What I later found out is that this young woman had been adopted from another country and had spent the first year of her own life in an institution. And my best guess is that she literally could not hear that baby cry, because that baby's, the level of distress that baby had was a trauma trigger for her, and she was literally dissociating, looking out the window, in order to protect herself. And again, this is all unconsciously, to protect herself from the high level of arousal that would create. And so that's part of the mechanism whereby the child can, him or herself, become the trauma trigger. It's like the toddler that walks away from me. You're going to be one more person that doesn't respect me. So the child just evokes all of those things from the past, and I may have an automatic response to how I parent this child based on my own experiences. And one of the jobs that as interventionists we do is trying to help parents begin to connect the dots. Well, what was it like for you? What do you remember? Do you ever remember a time when you fell down and got hurt? And how was that for you? Who helped you feel better? Oh, well, how would you like it to be for your child? So that bringing to the surface, and so that parents can realize they can have choices about how they want to do it. It doesn't have to be automatic. And that Ghosts in the Nursery is that lovely paper that Selma Freiberg wrote in the 70s, which if you haven't read is just made me cry the first time I read it. It's just a lovely description of how this Ghosts in the Nursery work. So when a parent, and again, I put the shark up there, the think shark music, that it's that physical feelings, the rapid heartbeat, these emotional overreactions, avoiding. I'm not even going there. It's you say, well, why don't these? There was an editorial in the Star Trib a few months ago about we're talking about racial disparities in the schools. Well, why don't these parents just get more involved in their child's education? Well, if school was a pretty traumatic, very highly stressful experience, why would I do that? So it's again, trying to understand using that trauma lens. And in one of the programs I used to work in is called the Circle of Women. It was for women with chemical health issues who were pregnant or parenting young children. And over, the women who abuse substances, the percentage of those women who have experienced trauma is probably 90%. It's huge. So again, substance abuse is often one of the coping strategies that gets involved when there's that history. So in terms of the impact on the parent-child relationship, how can the child trust the parent to keep them safe? They may remind each other, in domestic violence, for example, he looks just like his father was an abuser. Or, the child says, no, I won't, or the child, hits the parent and they're 12 months old and it's part of what little kids do, that can trigger a reaction from a parent that is that comes from a different place. And you can get both extremes. You can get the parent who sees the child as aggressor. This kid's out to get me. This kid's out to make me miserable. And if I experience my child as an aggressor, then I'm going to show him and I'm going to harshly discipline that child as a strategy. Or I'm a victim and I can't do anything. I can't set limits for that child. I can't work with that little monster. And so you can get some very extreme reactions to that when the parent actually identifies the child with the aggressor. The good news is we don't have to know what the trauma was, because often we don't. We just need to be aware of what potential trauma effects are, and how the trauma arousal affects the present. So what we want to do is join with the parent or the child. And what I mean by that is look underneath the behavior. For example, in one of the settings where I do consultation, We talk with a crisis nursery where parents can bring their children for up to 3 days when they're experiencing some kind of crisis and homelessness or whatever. And when we talk with the teachers, if you have a child who says, bitch, now I might handle that one way, but if I have a child that says, bitch, I can react to the fact that the child used that language. Oh, we have that on tape, don't we? Sorry. But when it's like that, if I'm looking at trauma effects, and that's the way that word comes out, that is a child who is terrified. That word was learned in a moment when that child was experiencing terror. And the way I'm going to handle that is not, we don't use those words here. I'm going to say, those words are so scary. We're not going to say those words here because it's scary to me, and it's scary for your friends, and we're going to keep them safe, and I'm going to keep you safe. Doesn't mean you let them say the word, but that's an example of how we don't have to know what happened, but we can make a pretty good guess that it happened under circumstances that were pretty traumatic for this child. So we think about development as, the blue line up there would be typical development. I have a 4-year-old child, and, we have motor skills, language, social, emotional, cognitive. We could go on and on, as if development were really this fragmented. And we're all better at some things than others, but typically a 4-year-old child who's had, optimal developmental experiences and so on and so forth, we would expect them to be at a 4-year-old level pretty much across the board in terms of their development. We have a child with delayed development, let's say with some kind of underlying medical etiology, 4-year-old child who really functions at about a 2-year-old level, and they function at a 2-year-old level pretty much across the board developmentally. This is somewhat exaggerated, but for our purposes. But then we have children who have had these kinds of experiences that may walk like a 4-year-old, they may even talk like a 4-year-old in many respects, but their capacity to regulate their emotions, their level of arousal, their attention, and their behavior is at a much, much younger level. And in order to work with them, we're going to have to meet them where they're at. So Anthony, 5-year-old Anthony, is this real macho little guy. I just love this kid. But he was the kid who would have these 30-minute tantrums when you said no at the beginning. But, for example, one day he decided, this is a couple of months into the program, and he was beginning to get the sense that, it works differently here. He decided he wanted to be carried off the bus and into the classroom. And if you knew Anthony, it was like, what? So for about 2 weeks, we carried him off the bus, and he would, ooh, and within another 2 weeks after that, he would not have been caught dead letting an adult carry him anywhere. But it was like we were filling in the gaps. It was how does it work here? You really going to do this if I say I want it? Okay, we'll do it. But when Anthony was in full-blown meltdown mode, we had to come down as if he were a 12-month-old, and then comfort him and help him be the regulatory partner you would be for a much younger child until we could work his state back up to where we could address the issue after he was regulated as a 4-year-old. The pink bike story. Anthony, the pink bike was the cool bike in the gym. I have no idea why. There were 4 to choose from, but everyone wanted the pink bike first. So when Anthony started the program, if Anthony couldn't have the pink bike first, you could kiss Anthony and a staff person goodbye for the remainder of gym time, 30 minutes, because of the rageful tantrum that would ensue. And so what we did is we pulled the kids together and said, Anthony's new here, and Anthony doesn't know how to take turns yet. We're going to all help Anthony take turns, and the way we're going to do it is we're going to let Anthony have the pink bike first. We promise you'll get a turn, but until Anthony learns this is how we're going to help him. And the other kids were fine with that because it was very explicit. It acknowledged that they had already figured this out. And sure enough, after about a week and a half or 2 weeks of Anthony got the pink bike first, Anthony was able to not have the pink bike. Now, a 5-year-old should be able to share, should be able to take turns. But Anthony wasn't a 5-year-old in that situation. Anthony was a 15-month-old. And until he had the experience of, I will get my turn, I will get my needs met, we couldn't expect him to share. So that's an example of how, with kids with these kinds of histories, we have to think younger, much younger. And again, not because we're catering, but because we're very intentionally filling in the gaps. And we can be very intentional with the child. I know you can put your shoes on. You're really good at it. But sometimes everybody needs a little help. How about if I put one shoe on and you put one shoe on? So the message is, you are a competent kid. I know you can do this, but I also know it feels good to have help. And so that becomes the goal of your teaching, which is not what you would typically be doing with a kid that age. Part of the problem is that we tend to, we are trained to follow the child's lead, right? We are trained to be responsive to parents and children. And so if the child says, get out, get away, okay, fine, we follow the child's lead. But again, this Mary Dozier, who's developed this program for infants and toddlers in foster care, we need to override that. If we're going to have our developmental lens and our trauma lens, we need to look underneath that. The child who is 15 months old and they fall down and get hurt, and we know that this child's experience is nobody reacts to this, or even worse, if I make a fuss, I'm going to get worse, I'm going to get hurt worse, so I just got to be invisible. And so you may approach me when I fall down, and I'm going to push you away, get away, get away. It's a survival thing. And so rather than, oh, okay, fine, which would be, an emotional response, but professionally we may say, well, I guess this is a child who. But if we have our trauma lens on and we know enough about the child's experience, we're going to say, it looks like you got hurt, and I'm not going to swoop this child up because that would feel intrusive, but I'm going to stay close. I'm sorry that happened. I'm going to be here. I have to learn to override my own interpretation and be willing to look underneath the behavior. What does this kid need? This child needs comfort, and I'm going to have to give comfort in very small increments. But eventually we're going to teach him how to do that. And the same is true of parents. The parent that, pushes you away. I love the no-show example. So you've been doing home visiting with this parent, and one day you say, I'm sorry, I'm not going to be coming. My supervisor's required me to attend a meeting. So you reschedule for the next week. You go out the next week. Mom's not home. Now, you can react to that. She knew I was coming. I called her yesterday and reminded her about our appointment. But again, with that trauma lens, that developmental lens, how might that mom really have experienced your rescheduling that appointment? She may have experienced that as you're abandoning me. If you cared about me, you wouldn't do that. And that may not necessarily be conscious. But again, it's just trying to see what underlies the behavior, whether we're talking about an adult or a child, rather than react like, fine. So we're providing that kind of reparative experience using our own relationship to both the parent and the child. So, and we need to have multiple perspectives. So if we think about it, I'll read you this little scenario, and then you see in this scenario, where do you hear trauma or potential trauma? So you've been doing home visiting with a mother and her 15-month-old toddler for about 2 months. There are frequent no-shows, and you dread the visits. Mom is very hard to engage in conversation, and she complains that her son is a spoiled monster, and he's just like his dad. The little boy is clingy and whiny, and he cries when you leave. Now, what do you think it might be like to be this child? You don't have, I mean, and we don't have a lot of information often. But let's just play with it. What might be some things that this child's experience? No consistency. Life, the world is chaotic. What else? I might be neglected. I can't count on, and here you come and you interact with me. What else? Yes? There might be possible domestic violence between the parents. And so what's the child's experience of that? So this is a frightened child, an anxious child. Anybody else?
Mom is disengaged with the child because it reminds her of her father, who she doesn't care for.
Okay, so the mom's experience might be that this child reminds her of the father, and she attributes motivations and intentions to him that are really not the case. So the child's experience of that might be, I don't know how to count on adults. An absent mom. She's here, but I can't count on her to help me. In fact, she's often mad at me for reasons that I can't predict. How about the parent? What might be like to be the parent in this situation? What are our hunches? Yes. Exactly. See, he cries when you leave. This child likes you more than he likes me, so why would I be glad to see you? You're just reminding me what a crummy mother I am.
Also, just some abandonment issues with the no-shows. You know, I'm just not going to show up and see if you still care about me.
Right, so mom may be testing your relationship. If I don't show, if you no show, or if I don't show up when you're here, when you're coming, I'm just going to see, am I going to drive you away? Because that's the way relationships work. If I act out, if I treat you rudely, if I don't show up for the appointments, you're going to get mad at me, or you're going to leave me just like everybody else. And I'm going to repeat that behavior over and over to see if it really works that way. So how often when you work with families do you feel like, I think there's a test here, and I don't quite know what the test questions are, and I'm either going to pass or fail. But that's real, isn't it? So what's it like to be you in this situation? What are some of the feelings this would evoke in us because we're human? Frustration. Absolutely. What else? Sadness at leaving that child. I like to call those two protective urges. Oh God, can't I just take this baby home with me? Again, remember, we're biologically wired to have that response. We can't not have the response. Our job is to be very aware of it and to be careful that we don't act on it or give a message that gives that away. So it's having to stay very in tune. What else might be some responses that you have as a practitioner?
Frustration on several levels, because part of it is there's a reason that they're involved with you, and she doesn't want to engage. So I guess suggesting that snippet is probably not voluntary, but it could be. And so that's frustrating because it's like, okay, I need to be here for whatever reason, and we really need to work on this, and she's not seeming to put forth any effort.
Right, I'm doing all the work here, right?
The other frustration is calling her child spoiled and he's just like his dad, and knowing that he's probably not being treated very well, and how do you get around that? Because
Right.
you can see the way she treats him in front of you. I can imagine what she's doing when you're...
And you worry about what happens when I'm not here. And so that creates that kind of anxiety, and talk about stress, right? I mean, that can be some of the stress that we deal with regularly in this work we do. You can see, though, how trying to understand the multiple perspectives and what might we guess this mom's history is. We don't know specifically. We don't have to know the trauma. We just have to know what the trauma, what is the evidence of trauma that we see before us. So she probably wasn't taken care of. She doesn't have she may not have a lot of experience with trusting relationships or what it is to have a regulatory partner. And so if her behavior is telling us what it is she needs from us. And so we have to override the overt message, which is get away, and find ways to go around it in ways that she can tolerate, so she can have that experience of a trusting relationship over time. Yes.
So how do you balance the typical agency rules of you break no show 3 times and you go on with the time?
I was really afraid someone would ask that. That's real life, right? It is real life. So the question is, what do you do when your agency has guidelines that says if there are 3 no-shows in a row, we drop this family from our caseload? Obviously that's not a trauma lens. And I think part of it becomes the need to educate the agencies within which we work and find other ways to deal with it. I don't have a magic answer, but I think that if we can use that trauma lens, take the information to the agency, and really try to let them know that there are other dynamics going on here. Healthy families. Is there anybody here with healthy families? One of the wonderful things about that home visiting program is that when a parent, you get 90 days without a contact with that parent, and you put them in a different category so they can remain on your caseload, and you're expected to continue to make engagement efforts. But it's built in, because these are high-risk families to begin with, we build in a category for these difficult-to-engage families. And over again, we see that if we can hang in there and persist, that in many ways is often the test that we're being expected to pass, and we can pass it, and we can re-engage that parent. Yes?
But on that same thing, sometimes you're not feeling traumatized parents, so even that doesn't always fit every family. So, the guidelines that some agencies have of the notions for some families that is appropriate because of what's going on in their family, or, pre-contact intervention.
Right. So you're saying that this may happen for reasons other than a parent's history of trauma, and you're absolutely right. But I think the message here is, if we use that trauma lens, it doesn't. I mean, the danger is we're going to see trauma everywhere, and we don't want to go to that extent. But I guess the takeaway message is we want to look and see what is the underlying meaning of the no-show. This no-show may be because this mom is really done with service and she doesn't know how to say it. I mean, you're right, there are other reasons why this happens.
Just going to the fact of really exploring who you are sitting across the room from and knowing what is coming. Using the trauma lenses and your other lenses too to be able to check what's going on. That's why it's so hard to work within agency guidelines.
Yes.
Make an overall umbrella policy when there's so many different.
Right. Yes, that is the challenge. If we set these rigid guidelines, there are any number of ways to interpret the same behavior. And we, ideally, as interventionists, we want to be able to respond to what our best guess is that this family needs. So, absolutely. So this is what we know kids need. And so when we're working with young children and their parents who've experienced trauma, we can try to become the regulating partner. That we are going to reinterpret the child's cues or the parent's cues, as we've been talking about. And in the process, if we can become accurate in understanding the child's cues or the parent's cues, the chances are the way they express things is going to become clearer. And that we're going to provide nurturing even when the behavior is challenging, whether we're talking about the parent or the child or both. That we will become that regulating, organizing partner. And this providing nurturance even when it's challenging, that's one of your handouts addresses that, taken from the Mary Dozier program. So we want to talk about being an organizing partner means organizing relationships. You can expect help here, whether you're an adult or a child. You can expect help from me. And again, that we can get into all kinds of how do you tell when they really need help, but organizing routines, and that means, we know what it means more for children, but for children who've experienced trauma, routines become that much more important in organizing. I need to feel like I know what's coming next, and I need to know you're going to walk with me every step of the way. But that's the same with adults. You're going to be there when you say you are. You're not going to promise to me more than you can deliver. And organizing language, again, that's something that you have a handout on. Megan Gunner has contributed to a curriculum called Early Development in the Brain, and she makes this wonderful kind of simplified way of thinking about stress, or that stress, any kind of stress, can be reduced by these three things: predictability, controllability, and social support. If I know that on Monday morning I'm going to have to switch my office, that's going to help me handle it than if I walk in the door Monday and my supervisor says, take your stuff and move it to another desk. If I even get to choose which desk I want when I have to move, as opposed to being told, I'm going to have a different kind of response. And if my supervisor says, not only that, I'm really sorry we're having to make this change, and I'm getting pizza just to make up for it, right? I mean, so again, that's a silly example, but these things can, so how we can provide the parents and children with whom we work, it really can help. Following the child and the parent's lead whenever possible, and again, so we're saying there's the dichotomy. We want to look for the underlying meaning of the behavior and respond to that, but at the same time, we want to encourage parents to follow their child's lead in play. If the child wants to stack those puzzle pieces instead of putting them in the puzzle, when we follow a child's lead, we are giving them the message that you are in control of your life. Right? It's about self-efficacy. It's about admiring that child. If I haven't had that experience in childhood of sort of being master of my destiny in something as simple as play, I'm going to grow up and feel like I am a victim of circumstances. The world happens to me. I have no ability to affect the world around me or my own destiny. So even though it's a simple thing, it has profound implications. Paying attention to our own reactions. This is where we need to think about our own capacity for self-reflection. Why do I dread this home visit? What is it about this? It's because the mom is this way. Why do I feel so hopeless when I leave this? If you're feeling hopeless leaving this home visiting situation, chances are you're dealing with a pretty hopeless, depressed parent. So all of that stuff that we feel, how we internalize these things, provides us with tremendous information for working with families. This protective urges we've talked about, and I call it going mama bear. And sometimes we're feeling protective of the parent against a system. Sometimes we're feeling protective of the child between the parent. And again, in order to see that, how is this mother experiencing me? I know what my intentions are in providing this service. She may see it very differently, and trying to appreciate all those perspectives. And then being aware that we are subject to secondary trauma when we're working with children and families. And again, this is taken from the National Child Traumatic Stress Network, that we can be secondarily traumatized in this work, and that we need to be paying attention to that as well. It can stir up our own life experience. We may be subject to that same kind of, oh my God, now what? Hopelessness, all of these, and we may become more irritable. Our capacity for empathy may become diminished. And those are symptoms and things that we need to pay attention to. And so the way to prevent that, again, reflective supervision. How many of you have the opportunity to participate in reflective supervision? Good. So it's that opportunity to partner with a trusted supervisor or professional that you can acknowledge the feelings that you're having. You can process, because it's relationship-based work, you can process the emotions and the things that go with it, And in telling the story, oftentimes we can come up with the solutions. And finally, just thank you for the important work that you do. It's really hard work, and I think a lot of what we do is a leap of faith. We don't necessarily get to see how the story ends, but we have to believe that we are impacting that story in very positive ways. So thank you for the work you're doing.